Welcome to the Minor Consult, where I speak with leaders shaping our world in diverse ways. Today, I'm delighted to be joined by Dr. Meena Seshamani. As Director of the Center for Medicare in the U.S. Department of Health and Human Services, Mina oversees the government health insurance program for seniors, covering more than 66 million people across the nation. Like me, she's an otolaryngologist and has practiced as a head and neck surgeon. And I'm pleased to say that our paths have crossed in this capacity over the years. Beyond the clinic, Mina has a PhD in health economics and has also served as a health economist and healthcare executive, in addition to her health policy leadership roles. Mina, welcome to the Minor Consult. It's great to have you here today.
Thank you so much for having me.
So, Mina, you earned your PhD in health economics before your MD, studying healthcare from a systems perspective before adding a clinician's perspective. What sparked your interest in healthcare on a broad scale?
Well, on a broad scale, I had started off, my interest in medicine really came from one-on-one patient interactions. When I was younger, I was volunteering in a hospital. There was a woman who told me stories during World War II. But I think I realized, especially as I studied economics in college, that so much of what happens in that interaction between a person and their caregiver or their clinician is shaped by the system in which they are. And I really wanted to have an opportunity to apply what was an academic interest in economics to really shape that system, to really enable us to take better care of people in our population. So I think that is what has really driven a lot of the work that I've done, from the one-on-one taking care of patients as an otolaryngologist to taking those learnings, taking those patient stories with me to drive major policy changes for a $1 trillion program in the country.
As a clinician, you cared for patients covered by Medicare. How has that experience informed your time at the helm of this government insurance program?
Oh, in so many ways. I will say one way is prescription drug affordability. There was one woman, her name was Mary, who was on Medicare, who had an ear infection that would not resolve. So, I was prescribing different antibiotics for her, and we would both get on our smartphones and look up at GoodRx to figure out what antibiotic I could prescribe for her that she could afford. And it's stories like those that I bring with me to this role, where starting January 1st of 2025, for the first time in the history of the Medicare program, we will have a $2,000 out-of-pocket cap on what someone with Medicare prescription drug coverage would spend out of pocket in a calendar year. And I think about my patients like Mary for that. Another example from that kind of really on the ground work to, bringing up one level, I led a lot of care transformation efforts for the health system that I was working at. And I remember having this huge spreadsheet with 8-point font of all of the quality metrics that our programs were being held accountable to across payers. And I know, as a clinician, the night before my clinic, when I'm reviewing my patients' charts to prepare for my clinic day, I wasn't looking at which payer each patient had to know exactly which quality metric I was being held accountable to. I just wanted to take good care of my patients. And I think that's another example of what I brought to my role here in Medicare, where one of the things that we have done is streamlined quality metrics across all of our programs in Medicare and at CMS with a universal foundation, a core set of quality metrics, so that rather than arguing about whether hemoglobin A1C less than 8 is a well-controlled diabetic versus hemoglobin A1C less than 9, instead let's enable people to focus on managing their diabetic population. So I think those are just two examples, both from that individual one-on-one patient care and then thinking from, a leadership position in a health system of some lessons learned that I've brought to my role here in Medicare today.
Thank you. And following up on that, the points that you just made, and in particular on your previous leadership roles in a large healthcare delivery system. When you were vice president of clinical care transformation at MedStar Health, care models that you led received national recognition. What did you bring from this role to your time now in public policy?
Oh, I mean, so many things. First, I was in this role during the time of the pandemic. And
Yes.
I think, leading community health, case management, all of our disease management programs, our care managers, that really became the fighting front, if you will, for the pandemic because the virus didn't respect the walls of a clinic or the walls of a hospital. And it really was about bringing care to where people are and taking care of them in their communities. And, I think what I realized in that role was the importance of having our system, coming back, Lloyd, to where we started our discussion today. How do you make the system actually reward that and support that moving forward? So, I'll give you an example. I led community health at the health system, and being able to make the case to hire a community health worker who does not bring in direct revenue because their services couldn't be billed, but we
Right.
all know how important their services are. There was one woman we had who was readmitted to the ED 17 times in 3 months.
Hmm.
And we paired her with a community health worker who went to her home and found that her electricity kept getting shut off. So her nebulizer for her chronic obstructive pulmonary disease wasn't working, and that's why she kept coming to the ER. So the community health worker helped to address her electricity. She was able to stay healthy and not come to the hospital. How do we make something like that the thing that is the standard to do in the healthcare system? And so coming to my role here in Medicare now, for the first time ever in Medicare, we are paying for community health services. We're paying for care navigators. We're also paying for clinicians to train family caregivers. As you know, being a surgeon, right, you're doing rounds at 5 in the morning. You have a post-op patient who's well enough to go home. They have this wound care that's needed. And it's almost like, okay, good luck, right, for the family member. And now to be able to put the resources of Medicare behind those very common sense things that can keep someone healthy in their community, avoid infections, avoid coming back to the emergency room, to the doctor's office, to the hospital. It's been wonderful to be able to take those lessons learned from caring for patients on the ground and from leading these kinds of initiatives in a health system to the policy level to enable that scaling across millions of people.
No, that's such a wonderful description, Mina. And as you said, you became director of the Center for Medicare in 2021. Coming into the role, what were your goals and what progress have you seen so far?
Yeah, well, so when I came into the role, it was July of 2021, which, as you all may remember, we were still very much, kind of in our homes.
Yep.
And I introduced myself to the team in Medicare. It's nearly 1,000 career staff. And I introduced myself to them in a Zoom webinar on day 2 on the job. Day 1 was new employee orientation. And I said to them, one of the first things that I said was thank you to them, because I had been helping to lead the COVID response for Maryland and DC, and all of the waivers that the Medicare team had put out to help with hospital throughput, to help with supporting, reimbursements for care being provided, differently because of the pandemic, how critical that was for us to be able to care for our communities during the pandemic. And I shared with them that what I was really excited about in taking this role was being able to work with them to advance health equity. I think we all saw the disparities that were brought front and center from the pandemic. To be able to harness the innovation that came to light in the pandemic, and how do we carry that moving forward so that we're really caring for people, not just treating individual diseases. And how can we be good stewards of the Medicare program and ensure affordability and sustainability? And Lloyd, one of the incredible things of working with the Medicare team, a few weeks after I did that initial Zoom webinar with them, I got a Word document with a table with equity, innovation, stewardship, like as columns, and the staff had populated it with all of their ideas
That's
of
great.
what we could do moving forward. And that really formed the basis of our 4-year strategic plan for the Medicare program. And, I did a vision blog in Health Affairs soon after I started, really inspired by the ideas and just the mission-driven work of the Medicare team. And that is what we have been marching towards in everything that we do in transforming care, like some of what I mentioned with the new and novel payments, our work in Medicare Advantage, and our work in implementing the prescription drug law or the Inflation Reduction Act.
Let's maybe move on to a little bit more to the Inflation Reduction Act of 2022, which gave Medicare the authority to set price targets and caps for certain drugs, as well as negotiate with drug manufacturers. Earlier this year, as you mentioned, Medicare announced the first set of drug prices. What do you think the long-term implications of the program will be on our healthcare system and on the development of new therapeutics?
Yeah, implementing the Inflation Reduction Act really has been an honor to be able to lead the Medicare team. And there are kind of 3 main buckets to the Inflation Reduction Act. The first are the changes to the prescription drug program. I mentioned for the first time there's an out-of-pocket cap of $2,000. We also implemented a $35 copay cap for a month's supply of insulin, as well as recommended vaccines at no cost sharing. The second bucket is inflation rebates, whereby if drug manufacturers increase the prices of certain drugs faster than inflation, they have to pay that difference back to the Medicare program to discourage those price increases. And the third big bucket is standing up for the first time ever the Medicare Drug Price Negotiation Program with our successful negotiation of the first 10 drugs. And setting up that program really enabled me to bring my experiences as a doc taking care of patients with my experiences and my expertise as a health economist, where we really centered the negotiation process on what really is a common goal for all of us, for drug manufacturers, for clinicians, for health plans, for patients. How do we make sure that people have access to the innovative cures and therapies they need at a price they can afford? And that really drove setting up this program, where we worked with everyone. We had an open door. We had monthly technical calls, regular roundtables, listening sessions to get ideas from everyone. And we grounded the negotiation process in data, and specifically looking at real-world evidence of how these drugs change the health of people's lives in their communities. And I think that will reap rewards beyond the Medicare program by really spurring a conversation of what are the benefits that these drugs provide. If you keep someone healthy and in their home, again, you are enabling them to live a more fulfilling life, and you're avoiding a hospitalization, right? Like when you think about how it impacts caregivers who are caring for people, and also really highlighting, do these drugs meet an unmet need? Do they impact different populations differently, which enables us to get at issues of equity and making sure that everyone has a fair and just opportunity to achieve their optimal health. So we had a successful first cycle. It is definitely not the last. We will be announcing the next 15 drugs by February 1st, according to the law. And my hope is that we have laid a framework of collaborative, transparent work that will further this dialogue and really make sure that we have really strong innovations that can really change health for our populations.
Mina, you've spoken several times during our conversation about the important role of family caregivers and what you and your team at Medicare have done in order to provide some avenues for compensation and recognition for the important work of caregivers, therefore hopefully encouraging more people to move into that realm. Can you also talk about the role that technology may play in assisting caregivers and also in bringing patients, Medicare recipients, into closer contact with the healthcare delivery system between their direct in-person encounters with that system?
Oh, absolutely. I think that technology has such a powerful role, as you said, to be able to connect across the various settings and environments that impact people's health. Because I think we all know that a 10 or 15-minute office visit does not encompass everything that impacts someone, and technology enables us to now have that reach. And so one example, we proposed paying for digital CBT, cognitive behavioral therapies.
Right.
Those are opportunities to be able to reach people where they are. And wherever we have had the opportunity by the Medicare law, wherever we've had the authorities to have more telehealth and to be able to expand those flexibilities, we absolutely have, including making behavioral health payments permanent, including audio only. And I think moving forward, we are definitely looking at more holistic ways of providing payments so that you can give that flexibility and those resources back to the people who are caring for those in Medicare to be able to figure out how to best use those resources in a team-based approach. So we've proposed more like bundled payments for primary care, for example, that an advanced primary care practice can use as they see they need to use them to be able to support populations, which means providing community health services or engaging a peer recovery coach to really move towards, again, those more holistic models that, again, I think technology can serve a very important role in, and being able to provide those resources up front that people can then use to invest accordingly.
Medicare insures such a large number of Americans, and you have in your systems a treasure trove of data about health, healthcare delivery, and healthcare outcomes. How are you thinking about the research components of what you do in your agency, but also the access to Medicare data by other institutions who want to discover things now that we're very much living in the world of data science and data-driven decision-making, to drive future directions of the program and also to let us know what's working and what could be working better with the program?
Yeah, I think this is so important. Ultimately, I am a clinical quality improvement person at heart, and it's so important that we have that culture of data, of analytics, of transparency to enable us to continuously improve, where we want to be able to make sure that Medicare data is available for researchers. Also, that we are providing data. And in fact, we recently asked for comment on data and transparency in the Medicare Advantage program, where we know that there's quite a bit of innovation happening in Medicare Advantage, where Medicare pays health plans to provide Medicare benefits to their populations, their enrollees. But there hasn't always been a lot of transparency around how that Medicare dollar is being used. What are the benefits being offered? Because there are innovations around health-related social needs, around care coordination. How is that being done? How is it being utilized? And how is that changing outcomes? And this is some of where I think the next generation of questions are for all of us, so that we can see what works, and what works we can scale. And it's inevitable that there may be some things that don't work, and that's okay, because that's learning too, for us to figure out how we then adapt and move forward. So I think for all those reasons, it's very important that we have good partnerships with researchers and with industry so that we can all continue to learn together.
You've mentioned, Mina, several times during our conversation about the importance of health equity to you, to the agency, and more broadly. Where do you see the greatest opportunities for Medicare to drive improvements in access and in health equity, and what do you think we should all be focusing on?
So how we define health equity is that everyone has a fair opportunity to achieve their optimal health, regardless of the myriad of factors that can impact it: socioeconomic, geography, race, ethnicity, sexual orientation, gender identity, language, etc. The only way that we can accomplish that is by integrating health equity into everything we do in a health system. It's not going to work if you have some pet project, here on the side on a shelf. Well, that's what I'm doing on health equity. Because when the healthcare system is fragmented, when it's not working, the people who fall through the cracks are the people who have complex health needs, complex social needs. So by making the system work, nuts and bolts operations in a more effective manner, that is going to address some of the disparities that have been in existence. So, as an example, we do a lot of oversight and auditing in the Medicare program. And I remember my team bringing to me a tragic case of where a referral loop wasn't closed for an elderly gentleman between the ophthalmologist and the primary care physician. And the gentleman ended up losing his eyesight. And, every time we do a meeting on any issue, we always talk about, well, what are the health equity implications of this? And the team said, well, this is what we always do. We always do oversight and auditing. And I said, okay, did the patient speak English? And the answer was no. Did he have any family support? What was his income level? And I think, you know the answers here, right? He didn't have the resources or the ability to be able to advocate for himself when the system was not working for him. So in everyday oversight and auditing, thinking about how we make sure that we are addressing the needs of everyone, including our most vulnerable. It also comes out in how we have rolled out additional graduate medical education slots. We are prioritizing 200 slots a year over 5 years to rural and underserved areas, because we know that, where people train, they're more likely to stay and practice, and they know the needs of that community. So again, in the very fundamentals of the medical training program, really keeping an eye towards equity. And where we are embedding equity in all of our quality programs, we have been using a strategy that we call rewarding excellence for underserved populations, where aligned across our various programs, for organizations that care for larger proportions of underserved populations, when they meet quality thresholds, they get extra reward, financial awards, so that they can invest in those communities, thereby creating that virtuous cycle. So those are all examples of how we're trying to embed equity in the very fundamentals, in the very foundation of the Medicare program, so that you can really address what are very systematic issues, from rural areas to people with limited English proficiency to people with multiple social needs.
Looking to the future, we know the population is aging, with the number of Americans ages 65 and older projected to increase by 47% to 82 million by 2050. At the same time, Medicare's trust funds are under considerable strain. What do you predict for the coming years, and what do you think needs to be done to ensure that seniors continue to access the care they need?
Yes, well, Medicare trust fund solvency is definitely something that is front of everybody's mind. And as we think about it, the Medicare program overall has 3 layers to it. There's the Medicare law, which is at the 50,000-foot level, which gives us the legal authorities to then implement the Medicare program. We implement the program through our regulations, which is at like the 25,000-foot level. And then you have how care plays out on the ground. And all 3 parts are key to delivering care to the 66 million people who rely on the Medicare program. So when we think about Medicare solvency, there are things that, Congress has definitely been thinking about at the Medicare law level. For us, we do a lot of work in waste, fraud, and abuse with our Center for Program Integrity. We also, to a lot of what you and I have been talking about, have been really trying to drive smarter spending of that Medicare dollar to provide better care and improved outcomes. And I think we've talked about some of the examples today, where we are creating more holistic care models that are caring for people in a way that keeps them healthier, keeps them at home, out of the hospital. And I think it's also equally important that we are partnering on the ground with people who are seeing where are people falling through the cracks, where can we work together to make sure that we're keeping people healthy and not spinning our wheels with someone coming back to the hospital 17 times because
Sure.
they couldn't use their nebulizer. So I think it really is all three levels that we are trying to work through so that together all of us in the healthcare ecosystem can make sure that the Medicare program remains affordable and sustainable for generations to come.
Mina, switching gears, I wanted to also touch on your career journey. From the hospital to Washington to the executive suite to home, what advice would you give what advice would you give to aspiring healthcare leaders?
Well, I absolutely believe in what John Cameron, who was the chair of the Department of Surgery at Hopkins when I was a surgical intern, said on our first day of internship, that if you love what you do, you'll never go to work a day in your life.
Yep.
Now, there are times where I feel like I am going to work, as I think we all do. But I really think it rings true, really finding what drives you, finding what your passion is, where you can make an impact, and just rolling up your sleeves, being good to work with, doing good work and being able to see that impact and seeing where there are those opportunities to collaborate and to be able to amplify what your impact could be.
Fantastic. Well, Mina, I want to end with two questions that I ask all my guests. First, what do you think are the most important qualities for a leader today?
So I think that the most important thing for a leader to be able to do is to galvanize good work of that leader's team and all of the partnerships that exist outside of that direct team. Because I think, I will say, especially in healthcare, people go into healthcare because they want to have an impact. They want to make a difference in people's lives. And how do you tap into that? And I think the way that you tap into that is severalfold. I think first, being able to approach things with open eyes and an open heart so that you can really get a sense from everyone what are the key things that we need to focus on and use that to create a vision and a strategic plan that can help to prioritize and guide work that moves forward in a clear-eyed way, because there are always going to be things that come down the pike, complexities, and always being able to return to that North Star is really key. I think the second is being authentic. Again, with that open eyes and open heart, acknowledging the humanity in all of us and in the work that we do, because that's what's going to enable teams to be able to get through something that's very tough, to be able to understand that things aren't going to be perfect and sometimes mistakes will be made. And the most important thing is doing your best to try to prevent mistakes and then learning from them when you move forward. And I think I would say the third thing is just being able to express joy and find that joy even in the tough times. And I think that comes along with the authenticity where, acknowledging when the going gets tough and celebrating successes and always engaging everybody else in that. Like anything that we have done in the Medicare program, in large part is because of the partnerships that we've had with everyone else. I did an interview with Modern Healthcare recently, and they said, many people have said this is the most active that Medicare has been in the healthcare system in a while. Why do you think that is? I said, because we're listening. Because I travel the country and I hear from people of what their pain points are, where do they see opportunities, where do they see successes. And those are the ideas that my team and I take back and we put into our policies. And then we go back out to all of the people and say, okay, here's what we've tried to do with you. Now, how do we make this come to life on the ground so that it actually makes a difference for people? I think that's the only way that we can really create change. And I think it's very important as leaders for us to embrace that and really harness the power of that partnership and collaboration.
And my second question is, what gives you hope for the future?
Well, in terms of the future, I have two children, 14 and 12. And a few years ago, my 14-year-old, who at that time was, about 11 or so, 11, 12, we have a journal that we were passing back and forth, like a mother-son journal. And it has like prepared questions. And one of the questions was, what are, 3 things that you admire about the other person? And my son wrote that I take good care of him and his brother, so I'm glad for that, that I have a kind heart, and he wrote, your work helps millions of people. And so I think what gives me hope for the future is the next generation who, really have experienced a lot during the pandemic, and children experience things, again, with open eyes and open heart. And, seeing in my own children and in their friends a true understanding of the importance of health, of the importance of health care, of the importance of policy and of people coming and supporting each other, and the importance of community. And I think that really is what gives me hope for our future.
Well, that's wonderful. Thank you so much, Mina. This has been a wonderful conversation. And thank you for listening to the Minor Consult with me, Stanford School of Medicine Dean Lloyd Minor. I hope you enjoyed today's discussion with Dr. Meena Seshamani, Director of the Federal Center for Medicare. Please send your questions by email to the Minor Consult at theminorconsult.com, and check out our website, theminorconsult.com, for updates, episodes, and more. To get the latest episodes of the Minor Consult, subscribe on Apple Podcasts, Spotify, or wherever you listen. And if you enjoyed today's episode, please rate the podcast 5 stars. Your feedback helps make this podcast happen. Thank you so much for joining me today. I look forward to our next episode. Until then, stay safe, stay well, and be kind.